So warm and a huge welcome to the World Health Organization and United Nations Population Fund launch and story slam of the Sexual and Reproductive Health and Universal Health Coverage Learning by Sharing portal. We're absolutely thrilled to have many of you join us today, and I know that many of you are also on the edge of your seats waiting for this portal to be launched. A fact is that globally, women and girls continue to face barriers to access healthcare services, whether it be transport costs, financial costs, or even language barriers. This portal is quite exciting as it's the first ever global resource which allows national level implementers and decision makers to have the access to how to address the sexual and reproductive healthcare issues. It's on this occasion that I welcome you to the launch of this portal. What is really exciting about this portal being launched today is that it houses practical national level implementation stories, which includes stories from decision makers themselves, stories from program managers, stories from communities, and even from civil society organizations. Thank you for tuning in from across the world. I'm Shakira Chinara, based at the World Health Organization, and we are hosted today by the IBP network and platform. To kick off this hour and this launch, it gives me great pleasure to introduce Dr. Pascal Alati, who is currently the director of the WHO Department of Sexual and Reproductive Health Research. Dr. Pascal Alati is quite new to WHO, but I understand, Dr. Pascal, you have over 30 years of experience in global health, and you've worked across 4 continents. So over to you to really kick us off this afternoon.
Good afternoon, and a very warm, or should I say hot, welcome from the Department of Sexual and Reproductive Health and Research at WHO, which includes the special program on research and training in sexual and reproductive health, co-sponsored by UNDP, UNFPA, UNICEF, WHO, and the World Bank, as well as several member states and visionary donors. Thank you for joining us today for the launch of the Sexual and Reproductive Health and Universal Health Coverage Learning by Sharing portal in partnership with our co-sponsor, UNFPA. We prioritize the sexual and reproductive health and universal health coverage agenda. And last week, we launched the first ever national level guidance on how countries can move towards prioritizing women, vulnerable and marginalized populations, and sexual and reproductive health needs within health systems, plans, and processes. We've decided to invest in storytelling, which allows for all stakeholders, be it government representative or a community leader, to understand the evidence to inform practice. I don't think we do this enough. We tend to devalue a lot of learning that we can take on from working and from learning from practice-based organizations. And so we would love for this to be the starting point for the development of important communities of practice through the Implementing Best Practice, the IBP network. This Sexual and Reproductive Health and Universal Health Coverage Learning by Sharing portal is designed to facilitate this process. Now, the portal offers both a platform and a resource to the global community to contribute to a growing body of evidence on the best practices, as well as the challenges for increasing universal access to sexual and reproductive health. 9 stories are showcased from settings such as Kazakhstan, Zambia, Pakistan, and Mexico, and we have several other stories in development and many more to come. We're building a body of evidence for an action-oriented agenda. And this, at the end of this, we hope that you will engage as much as you can so that we can ensure that we are speaking very directly to the needs of those who are going to be using it. Our partner, UNFPA, is critical to the development of this work. I welcome you to our story slam today, which clearly sets out what we need to do and how we need to do it, and the urgency of doing it and doing it now. The Learning by Sharing portal is an important step and catalyst to spur action on both SDG 3 and SDG 5, better health and gender equality. Enjoy the afternoon, enjoy the launch, and thank you for tuning in to this webinar. And thank you to our presenters who we hope will make this a really exciting afternoon for you. Back to you, Shakira.
Dr. Pascal, you couldn't have kicked us off in a better way. And I think the two key words to really get us started is story slam for this launch. As we jump ahead, and if the chat team could move to the next slide, but as we jump ahead, we're really looking towards what is the value of the universal health coverage and sexual and reproductive health learning by sharing portal. And to do this, we're turning to 5 inspiring and powerful women from all across the world. We've got Dr. Laleh Saif from the World Health Organization, Dr. Maha El-Adawi from the World Health Organization, Eastern and Mediterranean region, Dr. Julieta Onyebanjo from the United Nations Population Fund, Dr. Suchi Gaur, who's from civil society, the World YWCA, and I had a bit of a laugh, but also a good laugh, but you know, in the positive spirit when I saw your bio, Suchi. Suchi describes herself as an unapologetic feminist and a stickler for diversity. Now that's the way to go. We also have Dr. Teresa Soup, who's the research advisor at CEDA and the chair of the governing body of PCC. Over to the team to showcase the video, which highlights the perspectives from these key individuals.
Hello, my name is Teresa Soup, and I work as a senior research advisor for CEDA. In addition to that, I work with HRP, and I am the chair of the governing board of PCC.
My name is Laleh Sai. I'm the head of the unit working on sexual and reproductive health integration in health systems in the Department of Sexual and Reproductive Health in WHO Geneva.
I'm Dr. Suchi Gaur. I am the Director of Global Engagement and Impact at World YWCA, which translates into me looking at communications, programs and advocacy work and everyday strategy of World YWCA.
My name is Julieta Onyebanjo, and I'm UNFPA's Director for the Technical Division in New York.
My name is Maha El-Adawi, and I am the Director of Healthier Populations Department in the Eastern Mediterranean Regional Office of the World Health Organization.
Learning by Sharing portal came about with the understanding of the large gaps in evidence and implementation experience in including sexual and reproductive health in universal health coverage plans. As more and more countries are moving towards implementing a universal health coverage in their countries to improve the health of their populations. While countries are doing that, the evidence on how best to do from a sexual health perspective have been limited, and they were dispersed in different resources. So there are evidence in scientific literature, there are evidence from country reports, there are evidence shared in conferences and meetings, but we really wanted to make sure all this necessary information is placed in one place, on one platform, where people can go to and look at and search and find information they need.
So as a co-convener with WHO, UNFPA is just really extremely excited, deeply invested and really fully committed to the learning, sharing, and the knowledge efficiency that this new portal offers in our efforts to advance sexual and reproductive health and universal health coverage.
We also have a steering committee that is composed of external stakeholders from different perspectives, from research perspective, from implementation perspective, from policymaker perspective, to guide us in developing the content and the quality of the portal. So UNFPA and WHO are very proud to work on this together, but we are also grateful to our steering committee members to have that scientific oversight in the development.
One of the key things that I see as a big gap is looking at the issue of SRH from an intersectional lens of not just, health and the impact it has on other aspects like mental health, but also looking at it from an aspect of gender-based violence, conflicts that are existing in the countries, and the situation around funding and how women and the other genders, marginalized genders, are excluded from the conversation.
I think when we say universal, both in universal health coverage and universal access to sexual and reproductive health, we actually mean everyone, and no one can and must be left behind. Indeed, UNFPA works to leave no one behind and to reach the furthest behind, ensuring the inclusion of all marginalized communities, persons with disabilities, migrants, indigenous people, people of African descent, LGBTQI persons, and all population segments.
When we address gender-based violence in the health centers, this is an area of comfort where women can have access to medical care by whether a physician or a nurse or a midwife, and they have the freedom to speak, to express, and also where they can receive care in a much better way.
One of the things that we see lacking many times is adolescent health and migrant health, and really including all people in all countries of all different ages and situations.
I think it is important that elements of what is considered a comprehensive bundle of sexual and reproductive health services are not left out. Elements such as access to comprehensive sexuality education, to comprehensive abortion care, to detection and management of reproductive tract cancers, to STIs and other counseling services on sexual health.
It's important to understand how this is done, and that's another important issue, and to share good examples and experiences that are being made out in the world right now. So looking at different cases and sharing these stories, talking to each other, peer-to-peer learning, countries where you share similar experiences and challenges to find ways forward in this very important issue. There's a gap when it comes to how are the processes and how is decision making going on in different countries? Why are some interventions included? Why other interventions are not included? So there's a gap when it comes to evidence there. And we need to understand that so we can advance the agenda.
Sort of pressing issue is really political commitment, and that political commitment to sexual and reproductive health that translates into financial investments that ensure equity in access, quality of services, and financial protection.
I think it's also very important to know that we need to connect researchers with the decision makers and the different stakeholders, both to share the evidence, but also to do the priority setting. Where are the gaps? What are the needs amongst people and communities? So we need to involve the different stakeholders in this area. And there is also a challenge to get these people ourselves actually, to meet and to understand what the needs are.
We see very in-depth researches, but we rarely see the interconnections with the work, the theme. And I feel like with looking at it from a universal health kind of a approach is instrumental in the intersectional side of how critical SRH is. Very often I feel like we do these kind of very heavy top researches. We go and we speak to the community, but nothing gets flown back to them as to what is the next step, where are we closing the loop. And I feel like we are missing on closing the loop, because that's where the community gets disappointed and there's lack of accountability from our side. So I feel when we look at the issue of SRH and universalization of health, I feel it is critical to look at it also from an angle of community, and how closing the loop with the communities is important, because at the end we're doing it for them.
We expect with the use of the Learning by Sharing portal by different stakeholders from different countries to create a cross-linkages between the users of the portal. And we will be also developing a community of practice where the ideas, the experiences can also be shared in an interactive way across, not in a passive way, but in an active way by the users of the portal.
This is the whole idea of having a portal for learning by sharing. It's by definition, I think it's a beautiful name in a way, because we learn by sharing experiences.
Our call is that when countries are defining their national UHC policies and plans and the complementary benefit packages, they must commit to and have strategies in place to secure the full integrated package of SRHR services across the life course. And if one has to start with a smaller prioritized package based on available financial resources, then simultaneously structures and strategies must be defined for a progressive realization of equitable and universal access to comprehensive package of integrated quality sexual and reproductive health and reproductive rights services by 2030.
So the vision for the future, so we have the Learning by Sharing portal where you have guidelines and tools and the stories. So a vision would actually be to have it more interactive, so you can directly get in touch with people who share the same challenges. There can be seminars on the platform where you can directly go into some of the tools in your country or on global level and start to talk to each other. So that's my vision, at least, that this will inspire for connections and interactions between different stakeholders in different countries, and especially between decision makers, policy makers, the researchers, the communities, civil society actors, industry. So if there is enough interesting information for all of these different stakeholders, there's a great potential to really to advance the agenda.
People say that COVID-19 was a disaster. Yes, completely. It devastated the world. At the same time, it made us see all the gaps, and now we are working to fill those gaps, and that's the hope we all are carrying. And I see that the same way, the gaps that have existed in the way the researches have been done versus how stories have been told. I feel this Learning by Sharing platform is doing that, like filling those gaps. And that's one of the key roles we need to play for the future, because systems have operated in isolation and not interacted with each other, and we can't go that way for long.
To the 190 plus participants who joined us in from all across the world, welcome again to the WHO and UNFPA Sexual and Reproductive Health launch of our portal. As we jump ahead, and if the tech team could jump first, I think it's slide 5. The URL or the link that one needs to follow is www.srhr.org/learnuhc. This is where one can view the portal, view the implementation stories, and we have a collection of 9 stories already uploaded from the likes of India, Mexico, Nepal, etc. As we're shifting ahead, and we titled this launch Story Slam because we have 2 types of stories which are told, or 2 formats of stories. The one is we have written stories up on our portal, which shows the how to integrate SRH into our national health plans and policies. But then we also have the verbal storytelling, and our first storyteller for this launch is Professor Gustavo Nihenda, who on behalf of his team will present to us how is it that we're able to reach close to 10 million indigenous people in Mexico, over 60 different ethnic groups. Professor Nihenda, for example, paints a picture of the different models of healthcare which one is able to implement and to think about as a national level planner. On the one hand, one is able to go the public sector route, but also the critical role of civil society organizations. So over to Professor Gustavo Nihenda, our first storyteller for today.
My name is Gustavo Nihenda. I'm professor at the National School of Nursing and Obstetric from the National University of Mexico. And in that school, I do teaching and I do research, particularly in areas of health systems, health policies, and specifically on human resources for health and nursing, and as well in some issues regarding reproductive health in Mexican and Latin American populations. In Mexico, we have a little more than 10 million people that are considered indigenous, and they represent also around 60 ethnic groups. Most of these groups live in 3 southern states in Mexico, which are Oaxaca, Guerrero, and Chiapas. Indigenous populations for many centuries have been living in poverty conditions, and the investment that the public institutions make, particularly in health, is too low for them to have enough services to be provided. And we have been studying these populations in Chiapas and Oaxaca regarding the provision of sexual and maternal services in the states for indigenous populations. Indigenous groups are very special kind of people because they have their own cultural traits. They have a worldview quite different from us. They see reproduction and they see life in a very different way. So most of the history of the Ministry of Health or Secretariat of Health, the care is provided a different kind of way of thinking, mainly asking people to come to the health center, asking people to adapt to the standards of medical care. But I think it is important to have a 180 degrees turn, because we need to understand how these people behave, how these people think regarding particularly reproductive issues, which may allow us to be closer to them, to really be able to provide them what they need. Not only from where we see that need, but from the way they see the same needs, which may be experienced in a very different way. So understanding how indigenous populations can receive care, not only in reproductive health issues, but in general in other type of issues, it is very important. Well, in the last 10 years, Mexico has reduced the rate of maternal mortality from 55 to 35 deaths per 10,000. But in Oaxaca and Chiapas, this is maintained about 40 deaths per 10,000 births. So we decided to go and do this study to identify which were some kind of models of provision of this type of services for indigenous populations. And we found that in Oaxaca, there was like the standard type of healthcare provision, meaning that they are mainly practiced by doctors, and they are not using the protocol of respected or humanized birth. While in Chiapas, there is an NGO that is having a kind of agreement with the government to put in practice a type of model so-called humanized or respected. And also the provision is based on obstetric nurses instead of doctors. So these are the main difference of the two models. It is based on the right of women to decide some issues regarding the care. Two of them which are quite relevant are, first, the position in which the woman would like to give birth, and second, the possibility of having relatives or friends or even a traditional midwife that is accompanying the woman in the space where she is giving birth. So these are two main basic things but are quite relevant because they are not included in the standard model of care. Regarding the basic resources, meaning personnel and medicines and equipment and the spaces where the care was provided, there were not many differences. They were very similar. But in terms of the results of having the possibility of providing a care which was satisfactory for women, we found big difference because women are quite satisfied because they are given the possibility of having a position which they feel more comfortable, or even having the spouse or the mother or the traditional midwife accompanying them. So the level of satisfaction was very different in terms of this. But also we found that in the NGO, in between 2016 and 2020, they care for more than 500 deliveries, and none of these women had died or was reported as maternal mortality. And also those who were found that to be difficult to care, they were transferred to other level of care, which was a general hospital. This means that the group there, the nurses, they're not only capable of providing good care, but also they know exactly which are their limits in terms of what they can provide and what cannot provide. The place, which is called the birthing center in Chiapas, is within the premise of a general hospital. Interestingly, they started with this model, but doctors in the hospital were not very happy with it. And after 2 years, they started to understand much better which were the advantages. And today, they will be taking a course to provide care based on the humanized model. So they know also they have been identifying their own limits, but we know that they have a lot of capacities, to provide care. So the combination of both is emerging like something that it was not planned, but it is now a reality. And opposite in Oaxaca, we don't have that type of situation because care is still dominated by the traditional model or the standard model, and they don't have a clear idea what humanized or respected type of care it is. So take all this information and take all the experience to other areas to show how it can work beautifully when you combine both.
As you listen in to these implementation stories from across the world, we've just heard from Mexico, please do pop your thoughts on social media into the chat function on the IBP Network platform. We'd love to hear from you. What did you think of the story? Did you learn anything? And importantly, is there opportunity for scale up in your country, or can we replicate it as well? We're now going to shift as we move through our story slam of the WHO and UNFPA Sexual Reproductive Health and Universal Health Coverage Learning by Sharing portal launch. As we move to our next story, it will be featured in a little bit. Okay, let's give it a couple of seconds. The story is based on a community health organization up in Nepal. And as the team had worked on the story, what was absolutely fascinating were two things. The one is, and I suppose it was also quite alarming, thinking about how women still do not make decisions about their own reproductive health care. In Nepal, for example, it's found that women have their mothers-in-law, even their husbands make decisions about their healthcare. And the second component of the story, which is absolutely critical to the universal healthcare or universal health coverage debate, is the value of community health workers. For many of you listening in who run community health worker projects, you're well aware that they contribute massively to increasing uptake, increasing coverage of sexual and reproductive healthcare services. And this is essentially what this story, as well as several other stories on our portal, really portray. Community health workers are the solution to the universal health coverage of sexual and reproductive health services. For this segment, or the next story, we have two storytellers. The one is Dirpata Saud, who is a community health worker herself, based in Nepal, and the other is Sabitri Sabkota.
नमस्ते सबैजनालाई, मेरो नाम द्रुपता साउद, म नयाँ हेल्थ नेपालको सामुदायिक स्वास्थ्य कार्यकर्ता। विगत 3 वर्षदेखि म नयाँ हेल्थ नेपालमा कार्यरत छु। मेरो समुदायमा सामुदायिक स्वास्थ्य कार्यक्रम सुरु हुनुभन्दा पहिला स्वास्थ्य सेवा र स्वास्थ्य शिक्षा परोपकारी रूपमा समुदायमा र घर घरमा पुग्न सकेको थिएन। त्यसैले मानिसहरू आफूलाई भएको स्वास्थ्य समस्या आफू बाहेक कसैलाई पनि भन्न सक्ने अवस्था थिएन। साथै परिवार नियोजन के हो र यसका साधनहरू के छन् र यो कहाँ उपलब्ध हुन्छ भनेर पनि थाहा थिएन। त्यसैले थोरै समयको अन्तरालमा छिटो बच्चा जन्माउँदा र आफू सक्षम भएर नभएर बच्चा जन्माउँदा धेरै महिलाहरूको पाठेघर खस्ने समस्या भइरहेको थियो, जुन मेरो परिवारमा पनि म सानो छँदा मेरो हजुरआमाको पाठेघर खसेर निकाल्नु परेको थियो।
I'm Sabitri Sabkota. I work for Possible. I'm based in Kathmandu. Possible is a non-government organization. We collaborate with different organizations, including the government, for healthcare research and innovation. The situation that Drupadaji had just explained to us, this is very common in many remote and hard-to-reach areas in Nepal and outside. Basically, when you think about the mechanism to connect community people with health workers and health facility, there was no longitudinal mechanism in there. We wanted to have some innovative solutions to improve the life of women and the girls in there. So there was a global momentum that time around universal health coverage. And a lot of discourse for the role of community health workers to achieving universal health coverage. Naya Health Nepal, where Drupadaji works, and Possible, we sat down together with our Ministry of Health and Population, its divisions, and the local government. We discussed about what we should do, and we conceptualized and designed this community health program. The community health program where Drupadaji works, it's basically includes the community health workers who are from local community. They are trained, they get monthly salary, they are supervised and monitored by their supervisors. They use ComCare, which is a digital platform, and this is just not for the data collection. Community health workers, they use this platform as a guide for their counseling, care coordination, and referral. this is the broader community health intervention program, not just like, focusing on contraception, but part of this broader intervention, Drupata ji and her team, they provide person-centered contraceptive counseling. Drupata ji, tell us, how do you normally do?
हामी समुदायमा ब्यालेन्स काउन्सिलिङ 15 देखि 49 वर्षको प्रजनन योग्य महिला, त्यसभित्रमा पनि गर्भवती महिलालाई चाहिँ गर्भको 8-9 महिनामा र सुत्केरी महिलालाई चाहिँ प्रत्येक महिना हामी ब्यालेन्स काउन्सिलिङ गरिरहेका छौं। ब्यालेन्स काउन्सिलिङ गर्दा हामी महिलाको स्वीकृति मन्जुरीनामा लिएर गर्छौं। कहिलेकाहीँ उहाँको श्रीमान तथा सासूहरूलाई पनि सँगै राखेर ब्यालेन्स काउन्सिलिङ गर्छौं। ब्यालेन्स काउन्सिलिङ गर्दा हामी विभिन्न कार्डहरूको प्रयोग गर्छौं र अन्तिममा महिलाले छान्नु भएको कार्डको बारेमा विस्तृत रूपमा जानकारी गराएर उहाँलाई चाहिँ त्यो गरिसकेपछि स्वास्थ्य संस्था रेफर गर्छौं र अर्को होम भिजिटमा चाहिँ हामी त्यो कार्ड प्रयोग उहाँले त्यो साधन प्रयोग गर्नुभयो या गर्नु भएन भनेर चाहिँ सुनिश्चित गर्छौं।
During the process of implementing this program, our program team, they sat with local people and they adopted and tailored that to suit the local cultural needs of the community. Once we rolled out this program for a year, we looked at the data to understand how the program is performing. So basically, we found that in a year time, women during the early phase of postpartum, they are 2 times more likely to use modern contraceptive methods. And basically, this is because they are using lactational amenorrhea method. Women are exclusively breastfeeding their babies, in 1 year period compared to before we started the program. We found that community health workers, they played a significant role in educating women, their partners, their mother-in-laws about different types of contraception methods and its side effects and ways to address these side effects. What was very, very insightful for us as a programmer is women, they wanted to be counseled, at home rather than at the health facility.
हामी समुदायमा चाहिँ काम गरिरहँदा विभिन्न प्रकारका चाहिँ चुनौतीहरू देखा पर्दछन्। त्यसमध्येमा पनि हामी कहिलेकाहीँ ब्यालेन्स काउन्सिलिङ गर्दा श्रीमान तथा सासूहरूले चाहिँ मेरो बुहारीहरूलाई बिगार्दिन आयो भनेर लान्छनमा लगाउनुहुन्छ। उहाँहरूको मन जित्नको लागि हामीलाई केही चाहिँ समय चाहिन्छ। त्यसपछि त्यो कार्यक्रमको बारेमा बुझिसके पछाडी, साधनको बारेमा बुझिसके पछाडी चाहिँ सबै कुरा ठीक हुन्छ।
Our program shows that community health workers like Drupata, they have played a significant role in providing sexual and reproductive health services at the community level, which ultimately helping us to achieving universal health coverage. This program is so very impactful and promising, but this can be adopted and iterated, sitting down with the local people, local government and community leaders in order to match the needs of the local people. We have observed that this program has changed the lives of many women in this community and can also do the same for other women in remote and hard to reach areas in Nepal and elsewhere. One of the suggestions or one of the key things that they can take is we can design the program based on the evidence, which is which we can find in the global setting. But it is very important to sit down with the community people so that they can take ownership of this program. They can also adopt this program in order to suit the cultural and then the local needs of the people in there. And most importantly, the participation of different stakeholders in this program in order to make it successful and change the lives of people out there is very, very important. That's what we learned.
On behalf of the team, I do hope that if you're listening in, you're enjoying learning about different interventions from all across the world, and how do we integrate sexual and reproductive health into universal health coverage. Welcome again to our Story Slam, and we have one final story for today, but you can visit our portal link, which is www.srhr.org/learn-UHC, where you can access all of these stories, either in written format or verbal format. Our third storyteller, which will feature and showcase today, is Dr. Serik Tanirbeganov. We spoke a little bit about pronouncing his surname. Dr. Serik and team have put together a story on how do we advance adolescent health through transformative legislation. What we're seeing in today's times is rather punitive and restrictive legislation. We see that adolescents still face barriers to access healthcare services based on their age of parental consent, for example. And Dr. Serik and team take us to Kazakhstan to understand how they achieved the transformative legislation and what this means for access to healthcare.
My name is Serik Tanirbeganov. I'm working at UNFPA Kazakhstan country office as a national program analyst on sexual and reproductive health. The main message and the main idea of this reform that healthy teenagers today are healthy nation in the future. Young people in Kazakhstan, I think also around in the world, do not like to go to health facilities because in their point of view, health facility or clinic are the places of pain. Also, if a young person, for example, under age of 18 wants to go to the clinic, they have to ask mandatory their parental permission. And of course, the size of the country should be taken into account. The Kazakhstan is the 9th largest country in the world with a low population density. And this size requires to organize a comprehensive large network of health facilities. For example, in Kazakhstan, the network of youth-friendly health services before 2020 was only 100 youth-friendly health centers, like small places. But these 100 places, 100 centers, covered only 1% of young people in Kazakhstan. Based on our surveys, research, young people in Kazakhstan are not habit of using contraceptives, and as well as their knowledge on reproductive health is low. Of course, it is big problems, and as a result, there are high rates of unplanned pregnancy, and the number of HIV cases among adolescents and youth has been increasing over the past few years. UNFPA, together with Ministry of Health, made a partnership to change the current situation. And we find that for changing these barriers, to changing this situation, we need, first of all, to change a legal landscape. It means a comprehensive legal reform should be introduced in Kazakhstan, and we do it. We develop a comprehensive reform to implement into the national legislation the important provisions on regulating access to healthcare for adolescents and youth. And now, after 2 years of reform, youth-friendly health services are opening nationwide. Every young person from the age of 16 is able to get youth-friendly health services without parental permission. And these youth-friendly health services are free of charge and covered by the national health insurance system. I think our experience, such kind of reforms, is absolutely doable and can be replicated in other countries, in other cultures. But to replicate this experience, I think everyone should take into account three main things. First of all, you need to customize the best practice, best recommendations, or another solutions into your local context. Second, don't be afraid to promote your agenda, to promote your ideas among society, among government policymakers, or somewhere. And you need to find ambassadors, national partners who will support your ideas to promote among population, among society or policymakers. And number three, this is very interesting case. This is very comprehensive to develop legal landscape, how health services should be regulated. And in developing such legal landscape, you need to understand what does it cost and how to promote this idea among policymakers.
Well, there you have it. We've come to the segment where we've showcased three incredible and rich stories from all across the world. Again, you're able to access our portal at www.srhr.org/learnuhc. We're titling these stories video telling, but essentially you can also access the written stories on our portal. We do hope that you will utilize these stories, learn from these stories, share from these stories, but we'll get to you contributing in a little bit. As we now jump ahead, this portal, and as Dr. Lalesai had said earlier, is guided by a multi-stakeholder group, the expert review group, which includes Dr. Michelle Remp, Dr. Adriani Martin-Hilber, Professor Sophie Witter, Shannon Kowalski, Dr. Rodolfo Gomez, and Dr. Nandita Tate. Dr. Nandita is actually one of our collaborators for the launch today from the IPP network. We're going to switch over into what was supposed to be a speed round, and I'm now going to call it a speedier round, where we will get to hear from these experts, having listened to these stories, having been with us over the 2-year journey from developing the stories, providing ideas, and now seeing it all come to life, really offering very quick and brief reflections to mark this important launch of where we are and where we want to be. Shannon, you're appearing at the top of my screen, so I'm going to kick off with you.
Thank you so much. And I'm so thrilled to see the launch of these stories. Congratulations to the team at WHO and to UNFPA for their vision and leadership in pulling these together, and to those that submitted stories for this. So we know that sexual and reproductive health continues to be an area where, despite its centrality to women's and girls' health and well-being, it's often viewed as something that's nice to have, it's politicized, it's subject to overregulation, and is often under-resourced. So for many people around the world, in both high and low-income countries, barriers to sexual and reproductive health care continue to impede access. And when it comes to universal health coverage, we've seen that unless policies and programs and service packages are designed specifically with the goal of improving the health outcomes of women, adolescents, and communities who experience discrimination or marginalization, like migrants, Indigenous people, or people with disabilities, that they may not actually have any discernible impacts on improving their health outcomes. And further, we've seen that many people are left behind for reasons that have little to do with ability to pay, as we've heard today. So we do need to ensure that the design of policies, programs, and essential service packages are gender responsive, that they consider the needs of diverse communities, and that the full range of services and commodities, including contraceptives, abortion care, responses to gender-based violence, and maternal health care are fully covered. And we also need to ensure that they're delivered in a way that's appropriate and that meet women's and adolescents' needs, as we heard today. So these stories are really powerful because they demonstrate how governments and civil society can work together with communities to overcome barriers, define policies and service packages and programs that actually meet the needs of women, adolescents, and gender diverse people. So my hope is that by showing how this work is happening around the world, and most importantly, how we are improving health outcomes, that we'll be able to take these lessons, adapt them, and bring them to scale. Thank you again.
That's a great keyword to get us into our next speaker, Professor Sophie Witter. Shannon has just said, bring it to scale. Over to you, Professor Sophie.
Yeah, thank you very much. I'm very honoured to be included in this event. And I think it's really critical. I think a lot of us who are working on research and consulting, for example, as we travel the world, we see again and again the opportunities are missed where services are not offered at the right time for women, where services are fragmented, often linked to different agencies, different funding streams, and really that integration agenda is not happening. And I see this portal as being a really important opportunity to break down some of those silos, and particularly important to look at the way that we equip our health workers who often don't have the full set of skills to provide sexual reproductive health services alongside other UHC services, but also focusing on the kind of integrated package. And the stories are really important because they don't just describe the problems, which many of us are aware of, but they really try and provide some sort of positive examples of how those have been addressed. So I think that positive example and the storytelling is really critical. And it highlights also the need to address these multiple disadvantages. And I'd just like to mention here in particular, I've spent a lot of the past decade working on fragile states, health systems. And I think we also need to perhaps in future look at some stories that come from those areas, looking at the sort of additional layers of disadvantage that come from the kind of shocks and chronic stressors that many of those countries face, and some of the particular challenges, particularly for displaced populations and refugee populations, which unfortunately have been growing, and how we can provide the integrated UHC sexual reproductive health services that those communities need. And just to highlight a couple of other features which I think are really positive from the case studies, we're looking at the community needs, the needs of different segments of the population, but also really trying to understand some of the challenges from the health system. Health systems themselves have been under a lot of stress. And in this time of reduced funding and resource constraints, we really need to be thinking about how we get the priorities set to reinforce equity and rights. And from that perspective, I think it's really interesting that we bring in some of the political economy and legal aspects here. I think all of those have been well demonstrated in the case studies. And I think they speak also to the sort of learning health system agenda, which has risen up recently and has been promoted also by the Alliance for Health Policy and Systems Research, really looking at how you create the spaces in health systems to learn from local examples, create dialogue, innovation, and then scale that up. And they really bring out this intersection that has to happen between research, data, and practice. So just a big congratulations to everybody who's worked on them. I think we've got more examples we can bring onto the portal. I think it'll be a tremendously useful resource. Look forward to working with you as we go forward. Thank you very much.
And thanks, Professor Sophie and team, for your support over the 2 years in getting us to this point. Dr. Rianim Martin-Hilber, you know, when I read your bio, something struck me that you've worked over 25 years really championing reducing access barriers to sexual and reproductive health services. So over to you.
Hi, everyone. Thanks very much, Karen. It's really exciting to be here. The sharing and learning portal, I think, is a fantastic approach to actually bringing the stories that so often we miss when we go around. I've been evaluating health systems strengthening efforts and adolescent health programs in countries for years. And oftentimes we see a repeat of similar challenges as well as similar mistakes, unfortunately. And often I find myself telling a story from another country. Oh, well, they actually did this, or there was a model law or something. And these are the kinds of things. Oh, really? Can you send me the information? The Sharing by Learning portal will actually provide that space for them to just check in, see what's there, and adapt their own programs. Particularly, I have witnessed various efforts to integrating SRH services challenged by known problems such as human resource shortages and service pathway complications that limit access to integrated SRH services. Access to critical services on safe abortion, mental health counseling, reproductive care, reproductive cancer screening and treatment, and appropriate adolescent healthcare services are among the most difficult to mainstream. Other services, such as CSE, require new partnerships for SRH implementers and advocacy partners in the education sector that often brings us back to making the case for SRH information and knowledge to new partners, a challenge we have largely overcome within the health sector. But within the education sector, we are again in the position of having to make the case, particularly for girls and young women. Now we increasingly engage across sectors to make the case, which brings additional challenges, but also opportunities for holistic SRH programming for adolescents. But through my work, I've also seen innovative, dedicated staff in remote areas in capital cities succeeding in bringing integrated SRH services. I was really excited about the presentations from Mexico and Nepal about reaching traditional societies. I think one of the biggest challenges has been in adapting our messaging to be heard. And I think that it starts with, and as we saw from their case examples, it really starts with them talking to the implementers, talking to the populations, and having the populations actually express how they want to hear and how they want to receive the information, and us adapting to them. In both cases, engaging directly with the local populations allowed the adaptation of messages to their concerns. The change of the legal and policy framework by UNFPA in Kazakhstan, together with their partners, was absolutely essential and has been also one of the underpinnings of improving adolescent sexual and reproductive health. They show us that legal change can expand access to SRH services for young people through legal reform and creating this enabling environment. Again, localizing the issue in the context, championing the ideas to promote access, and being courageous in doing so was highlighted, which I thought was really wonderful. I think that one of the biggest challenges we see when we talk to people in different countries trying to advance perhaps sensitive issues is that it does take a champion, it does take courage. And I think that if we're really going to integrate sexual and reproductive health and advance adolescent health, we're going to have to be courageous to actually bring these issues to the fore as critical, particularly for the demographic dividend and others. I think that the Sharing by Learning portal is actually a tremendous opportunity to bring those stories and those examples to bear. So thank you so much for having me be here and to participate in this tremendous event. Thanks so much.
Thanks, Adriani. And I think you're pointing to the opportunities, and another big word you use, which I think is so critical to this portal, is the champions, and having stories written by champions themselves, many who we heard today, but those who are also posting in the Q&A, such as Joy Walibuta, who's leading the work on the last mile health in Zambia. Her story is also featured on the portal. And so I think the portal, as it was said earlier when we opened through the high-level speaker video, how does it become interactive? How does it become a community of practice? And I then shift to Dr. Michelle Rem, who I remember having a conversation with 2 years ago. You were out in Malaysia and you had said something which stuck with myself and the team throughout the process, which was the end user, the person who uses this portal is going to be critical. So over to you, Dr. Michelle.
Thank you so much. Thanks, Shakira, and many thanks to the organizers for this wonderful event and for inviting me to say a few words. I also wanted to say a huge congrats to the team and everyone involved for launching this Learning by Sharing portal. It really is a fantastic resource, and I hope it will be used to its full potential. This is an area where we need more knowledge sharing and evidence. And when I say evidence, I don't mean necessarily more randomized control trials or other forms of experimental technical evidence, which are, of course, incredibly important. But we're talking about integration of sexual and reproductive health and rights in universal health coverage. That is deeply and inherently political and complex. So to do it well and to keep doing it better, we need to understand and we need to be documenting the political and the influencing strategies and mechanisms that can be effective in specific contexts to really move the needle and to drive this agenda forward. And I think this is where we have to get better at valuing practice-based knowledge. And we do ourselves a disservice, in my opinion, in the field by overly privileging biomedical evidence and undervaluing other forms of evidence. And we all know and perfectly understand that improving health and well-being goes beyond the biomedical. But we're not as good in systematically analyzing and unpacking what has worked, how did it work, why did it work, for whom did it work. So I think this is so exciting to see that WHO and partners are increasingly embracing these diverse forms of knowledge and learning and providing spaces and creating spaces for them to be shared. And I think it's yet another invaluable contribution of the rights field to public health. There were so many fantastic stories. I think in the Chapa story of respectful care, it was very clear that this humanized model of maternal care was both the right way to go and also the most effective. And having that knowledge was no doubt important in getting the willingness from the traditional medical community to learn from this model. But also, I think this openness to learn and to enrich our models of care is so important and must be the way the field advances to leverage different forms of knowledge, create spaces for practice-based learning, exchange, and adaptation. So once again, thank you to everyone who brought this resource to life and calling on all those working at this intersection between SRHR and UHC to share their knowledge and experience generously and candidly. And very much hope that through this engagement, we can all further sharpen our collective skills and toolbox to advance this critical, life-saving, and life-shaping agenda of integrating SRHR and UHC. So thanks so much. Back to you.
Thanks, Michelle. That's really powerful. And now over to an advocate who has been pushing for translation of the stories, making sure that stories are submitted in French and Spanish, not resting. In phase one, we're still in English, but we promise in a couple of months we will have the other languages featured. And so holding ourselves accountable to that during this launch, Dr. Rodolfo Gomez, who's also an ERG member for the portal and also really a focal point and such an activist and advocate for SRHR in the Latin America region.
Thank you. Thank you very much indeed, Shakira. And I'm really honored to participate today with you. As an OBGYN and as a sexual reproductive health advisor for the Pan American Health Organization, I'm really moved by the Mexico story that I want to focus in few things. We have in our region in Latin America around 29 million indigenous communities, indigenous people living in there, and 12 million around Mexico, and and maybe 6 million in Guatemala. But in the population is 6% of the total Latin American population indigenous. If we think in the example, in the beautiful example that Dr. Gustavo shared with us today, we can think that maybe this is only appropriate for indigenous communities. And I want to tell you, it's not. It's incorrect to think that this tailor-made intervention using the free position for birth and with a companion in birth is only for them. WHO published many guidelines recommending those as the most evidence-based practices. We have in our region too many interventions too soon that create a lot of C-sections and suffering and health problems, not only for the mother but also for the baby. And in few places we have few interventions too late that we need to implement to save lives. And I see the portal as a very good example on how to translate not only in language, but also translating the concept, the theoretical concept, into the reality, into the how, when, where, and what effect have the intervention. Not only reducing maternal mortality, but also increasing birth as a positive experience, and not only reducing maternal mortality, but also reducing maternal near misses that are, really the focus for us in our region. The perceived quality of care could be two things. Could be a breach if the quality is very good and the community knows, or could be a wall that stop community coming to the health system. And I see this example that Gustavo shared with us, a very good breach because the quality was good and the community was participating. But I want to mention that quality of care must be used in the integration of the full health system. There are many world interventions, like, for example, the IMBCO initiative or organization that defined 10 steps, or the FIGO initiative that defined 12 steps to humanize care, the positive birth experience that the guideline that WHO mentioned, not only with the vertical position for birth, but also reducing unnecessary interventions like vaginal examination and others. And I want to mention a very nicely done supplement on the BMJ that WHO published recently with the positive experiences, that increase the quality of birth care. And I think that coming back to the rights point, we can say that all the best practices must be for all women, not only indigenous women, because we have a very strong evidence-based information in there that we have to use. And the intercommunication and the integrated health system, private, public, first level of care, secondary, and the referrals are the way that WHO is recommending. And I congratulate all the examples that we see today, but I want to especially congratulate Dr. Gustavo Negenda from Mexico with a fantastic experience. Thank you very much. And I'm really honored to be today with you.
Thanks, Dr. Rodolfo. And yes, to more stories and more evidence and growing something which can be used for advocacy. Nandita, you've been on the edge of your seat. It's so interesting that you run the IPP network with the team. And what are some of the synergies you're seeing having joined our launch and getting to know a little bit more about our work over these past few weeks?
Thank you, Shakira. Well, that's the perfect question. Is sort of what is the value of these kinds of stories? And I want to just focus on three that we witnessed as part of our experience launching implementation stories in family planning and reproductive health. One, interventions are not implemented in isolation. Research articles, for example, often focus on the impact of one intervention, which is critically important to demonstrate that evidence-based impact. However, stories like this allow us to see that it is often multiple interventions delivered in a package that can really improve SRHR and UHC outcomes. Number two, what I noticed in these stories, similar to what we saw, is that there are often other best practices that are critical to making a successful program. Things like mentoring or team building can really make or break a program, and stories allow us to document those experiences as well. Related to that, stories provide a safe space to also document failures. And this is something that we've been working on and encouraging our partners to share, as there's a lot that can be learned about what doesn't work. And stories provide a really safe space to be able to share those learnings as well. And finally, what we're seeing is that SRHR programming is intersectional and intersectoral. And stories like these often allow us to see this firsthand. So addressing issues like gender, poverty, equity are critical to make sure interventions address all communities. And then engaging with diverse stakeholders, not just ministries of health, but ministries of finance, ministries of social welfare, and other sectors can really help ensure that these interventions are sustained over time with a sustained commitment by all partners. So with that, I'd like to congratulate you and the team once again for sharing these incredible stories. We very much look forward to contributing to this work. Thank you.
Thanks, Nandita. And you raise one very valid point for those listening in and who want to contribute stories, is we also have stories which show the challenges of integrating sexual and reproductive health into UHC. And we want to know more about that as well, because it's important insights to think about what works, but what doesn't work when you're making decisions at a national level. Shifting us to the closing, really the two driving forces and also the coordinators of this body of work on sexual and reproductive health and universal health coverage, Geeta Lal and Vilashni Govender. Over to you to close the launch officially. Geeta, let's start off with you.
Thank you so much. After such a rich discussion, what more is left to say? Good morning, good afternoon, colleagues and dear friends. I honestly, I'm left speechless. Firstly, I'd like to extend a huge warm thank you to all my WHO colleagues, Lale, Vilo, Shakira, George, Torsten, Nandita, the advocacy and web teams who did all the recordings and work on the platform. This is really, really wonderful and a much needed partnership that helps fill an essential gap around the how-to. You know, we talk about SRH and UHC, but how do we integrate SRH within UHC? Thanks to all the authors for the wonderful case studies, for your work on the ground. Thanks to all the panelists and ERG members for your sound reflections on why we need this platform and how to make SRH integration within UHC a reality. Shakira, brilliant work and also brilliant moderation. This has been an eye-opener for all of us. We all know there is no UHC without sexual and reproductive health, but this is also not an easy job, and that has come out amply today. There is the word universal in UHC, and this implies that no segment of the population can be left behind, and we need to be inclusive. And we all know that is not simple. Secondly, we need a comprehensive integrated life course approach that we have seen to SRHR. And from stories today, we also know that you need a culturally sensitive and context-specific approach that are equally important. System, financial, legal, and policy constraints are many, and mobilizing stakeholders and understanding the context and the gaps is really key to the solution. There is also no magic bullet. We are not quite there yet, but I think we are all on the right track. The kind of learning that this portal can offer can help us all with the progressive realization of SRHR interventions at various health system levels and ultimate inclusion of all SRHR elements within UHC. The limited cross-section of case studies that we have heard that are on the platform today currently offer scalable solutions. Several are in the pipeline and will be published in due course, but we need more and more contextual solutions. And as Nandita mentioned, maybe also things that did not work. There is a lot more to learn, and we can collectively realize the important objective of mainstreaming SRH within UHC. We need to keep growing this compendium of qualitative, practical case studies for which we seek your support and help us in identifying promising initiatives. This platform should ultimately become the go-to site for SRH and UHC integration. So please help us spread the word and help us identify more case studies. Thank you all so much for joining today. Over to you, Shakira.
Thanks, Geeta. And I think you're spot on in asking the audience and spreading the word beyond those who are attending to, one, submit stories, two, learn from each other. And now over to Vilashni Govender, who again is the coordinator of the Learning by Sharing portal globally, but also a mentor to many of us, an economist. And I read on your bio yesterday that you've been doing quite a lot of pharmaceutical work in your past life, Vilash. So over to you.
Thank you, Shakira, and thank you, Geeta. I'm not going to repeat, I think everything Geeta has said, I support 100%. We are super grateful for this fabulous collaboration with our colleagues in UNFPA and the incredible support we've received from Julieta and Geeta. And I probably have less than 30 seconds, but bear with me, I'll take a minute. Keith has also, very eloquently and passionately reminded us why there is no UHC without SRHR, but getting there is no easy task. As she's also reminded us, there are systems, political, legal, and policy constraints, and we've seen this from the case studies or the stories we've seen today for achieving universal access to comprehensive SRH. And through the process of developing the LSP, or the Learning by Sharing portal, we have learned many important lessons along the way, bound to learn many more as we proceed, but especially from you, the audience, and those who have submitted stories. I would like to just very briefly share some of these lessons with you, because I think they're important for us to reflect as we move forward. First, we have learned that while the evidence is limited, it does exist. And this is evident from the large number of submissions we have received in response to the first call last year, and which have showcased creative strategies and solutions on the ground, confirming that SRH UHC integration is already underway and being implemented by multiple stakeholders. Also, as Michelle noted, these are diverse forms of knowledge that need to be encouraged and that we need to be able to showcase. Second, we've also learned that to build the evidence, we need to ask the right questions, encourage participation from voices in the field, and also trust the process of co-development in what Sophie described as learning health systems. Third, we have and we continue to learn that the importance of collaboration, collective action, globally, regionally, and at country level. And we also extend our appreciation to our regional and country officers for their support. And thanks again to Rodolfo for all his support and our other partners in the other regions. And finally, we have also learned that the LSP will not fulfill its role without the active participation from you partners in the field and end users. Therefore, we encourage, welcome, and very much need your feedback on ways to improve the LSP and ideas and opportunities for cross-learning and building two-way engagement. So please feel free to reach us with ideas and stories. And on that note, I would like to thank you all again, and thanks for everyone who's contributed to the portal and to the launch today, and wish you all a good day. And back to you, Shakira. Thank you.
Thanks so much, Blush. 2 or 3 minutes of your time if you're listening in to the launch of the UNFPA and Sexual and Reproductive Health and Universal Health Coverage Learning by Sharing portal. We once again want to thank our expert review group members, some whom you've heard from today, but others who you had not had a chance to hear from. Their ideas, their energy, their guidance, their advice, their support has shaped this portal, and really their expertise as well. So we thank all of you for your contributions. Jumping to the next slide, we do have a core team in place, but we also have a broader team. We have worked with web developers. We have worked with UHC partnerships. We've worked with civil society organizations like ThinkWell, Concept Foundation, and others. And so we'd like to really give you a shout out during this launch and thank you for your contributions. We do have our story coach, Deborah Abrahams, who's also online. She had spent time with the authors to create their video telling stories which you heard. And finally, and once again, for your utilization, if we can skip to the next slide, for your utilization, for advocacy, for continuing to build the evidence, and also we invite you to be contributors. Are you working on a project which you're seeing is advancing sexual and reproductive health and universal health coverage? Get in touch with us. Our details are up on the website, www.srhr.org/learn-UHC. You will be hearing more from us, and we look forward to collaborating with you. Adios from the team LSP, and thank you for joining our launch.